Okay, fantastic. So it's a great pleasure to have Dr. Rossitza Lazova, who completed the residency in anatomic and clinical pathology at the University of Rochester Medical Center in New York. She trained with Dr. Ackerman at the Institute of Dermatopathology at the Thomas Jefferson Medical College in Philadelphia. After she finished this fellowship, she started a very productive academic career at the Department of Dermatology, Yale University School of Medicine. Dr. Lazova's main interests are in melanocytic lesion, and particularly Spitz-Nevi, spitzoid melanoma, and conventional melanoma. She recently introduced mass spectrometry imaging as a method to aid the diagnostic process of difficult melanocytic lesions. She taught many courses, directed numerous sessions at national and international meetings around the world. She has been the director of the Dermatopathology Fellowship at Yale University for more than 14 years, and she trained many fellows and residents. She has developed an international program and has supervised and taught over 50 physicians from 4 continents. So she's really a giant of dermatopathology, and we are very grateful that she is lecturing with us, and she's going to talk about cutaneous manifestations of connective tissue diseases. Thank you very much, Rossitza, again, for accepting this invitation and coming to the program.
Thank you, Laszlo, for this very kind introduction. I'm very happy to be able to do that, and it's an honor for me to be able to speak in front of through a webinar to many colleagues from different areas of the world. Today I will discuss cutaneous manifestations of connective tissue diseases. The diseases we're going to talk about are lupus erythematosus, dermatomyositis, systemic sclerosis, scleroderma, and rheumatoid arthritis a little bit. So what is lupus erythematosus? It's an autoimmune disease. We don't know the exact cause of the disease, and therefore we cannot treat it. Presumably, the body reacts to self-antigens that are considered foreign after some changes in the body. So the body attacks its own proteins and its own tissue, and the results of the tissue damage is obvious. Now, there are several variants histopathologically of lupus erythematosus, depending on the depth of the inflammatory infiltrate. And here on the screen, we have a schematic delineation of the different types of diseases, the different types of lupus. The first one is ACLE, or acute cutaneous lupus erythematosus. In acute cutaneous lupus erythematosus, the changes are only near the dermoepidermal junction. The dark brown dots represent inflammatory cells near the junction. In subacute cutaneous lupus erythematosus, the inflammation is more dense, and again, it's near the junction. The next type of lupus, discoid lupus erythematosus, in which the inflammation is superficial and deep throughout the reticulodermis, in addition to some changes at the dermoepidermal junction. The fourth type of lupus is tumid lupus erythematosus, in which there are no changes of the dermoepidermal junction. The epidermis is unaltered. All the changes are in the dermis. And then the fifth type is deep lupus erythematosus, or subcutaneous lupus erythematosus, also called lupus erythematosus profundas. That is why the abbreviation LEP. In this type of lupus, the inflammation is only deep in the subcutaneous fat. Occasionally, it may spill out into the lower portion of the reticulodermis, but it's located very deep. Lupus erythematosus is a systemic disease. Many organs are affected, and only one of them is the skin, but the skin is certainly affected in at least 60 to 80% of the cases. Now let's talk about the different types of lupus erythematosus. Acute cutaneous lupus erythematosus usually is seen on the face, particularly the malar area of the cheeks, and presents with a butterfly rash. This rash usually appears after sun exposure, but in general, lesions of lupus erythematosus are either exacerbated or appear for the first time after sun exposure. So sun exposure is not good for those lesions. And in addition, they are present on sun-exposed areas. The head, the neck, and the V area of the neck are very common locations. The lesions are transient. They can appear and then they can improve, completely heal, and new may appear. The duration of those lesions are from a few hours to several weeks, and they can resolve without scarring. Here is a clinical example of this malar rash on the face of a child. We see erythema on the cheeks and also over the dorsum of the nose. Here a slightly flaky rash, but very similar, erythema over the cheeks and the dorsum of the nose of this child. And what are we seeing histopathologically in cases of acute lupus erythematosus? We'll go later in describing the features, the histopathologic features of the other types of lupus, in which the lymphocyte is the predominant inflammatory cell. However, it's very important to understand that in acute lupus erythematosus, the neutrophil is the primary inflammatory cell in lesions of acute lupus erythematosus. What are the findings? The findings are subtle. We see neutrophils. Can you see my pointer or not? Probably yes.
Yes, we can.
Wonderful. So we see neutrophils that are present within the papillary dermis, and often they are aligned at the dermoepidermal junction. There may be some lymphocytes around superficial vessels, but the infiltrate is located only in the superficial portion of the dermis. And again, neutrophils are the main inflammatory cells. At this higher magnification, we can see how the neutrophils approach the dermoepidermal junction. There is vacuole alteration of the basal layer keratinocytes, as seen here. And then there is some papillary dermal edema in the around the superficial vascular plexus. We may see a few lymphocytes, but again, neutrophils are the main inflammatory cells. Since this is acute lupus erythematosus, these lesions are acute, so there is not enough time to form any changes of the basement membrane. So there are no changes, no thickening of the basement membrane. The main findings, again, are vacuole alteration of the basal layer keratinocytes and neutrophils in close proximity to the basal layer of the epidermis. Occasional necrotic keratinocytes may also be seen. Here again, a higher power magnification of the neutrophils close to the dermoepidermal junction, prominent vacuole alteration of the basal layer keratinocytes, and perhaps one keratinocyte on its way to necrosis. Sometimes acute lupus erythematosus can produce blisters because the separation between the epidermis and the dermis due to the inflammation that is present there can produce blisters. And here is actually one small blister in this specimen. I will go to a higher power. Again, numerous neutrophils that are seen at the dermoepidermal junction, and then a collection of neutrophils that lifted up the epidermis and produced a small vesicle. So this is a subepidermal blister, and it's due to the inflammatory cells filling up a blister cavity that originated there. The necrotic keratinocytes that were attacked at the dermoepidermal junction were disrupted, and that's how the blister formed. Here again, neutrophils and mucin and extravasated fibrin within the blister cavity. Necrotic keratinocytes within the epidermis. Subacute cutaneous lupus erythematosus is another type of lupus, which is photosensitive. The lesions are confined again to some exposed area. There is the mid-facial skin is usually spared, but the sides of the face and the V of the neck and extensive surfaces of particularly upper extremities are often involved. And here are the sides of the face involved by those lesions. So no heliotrope rash, but then sides of face and V-neck. This is the back, but we can see how these lesions have somewhat irregular shapes, serpiginous in a way, shapes of erythema and scale. More of these lesions on the back of this patient. And unfortunately, this photomicrograph is not in great focus, but in subacute cutaneous lupus erythematosus, as I mentioned before, in all other types, lymphocytes are the main inflammatory cells. And we see lymphocytes around vessels of the superficial plexus and lymphocytes approaching the dermoepidermal junction. There are vacuolar changes in the keratinocytes in the basal epidermal layer and occasional necrotic keratinocytes. The basket woven keratin layer is not changed. Here is another example of subacute lupus erythematosus with numerous lymphocytes abutting the dermoepidermal junction. As we can see here, many of the basal layer keratinocytes show vacuoles in their cytoplasm, which is vacuole alteration. And maybe this is a necrotic keratinocyte, but there is definitely interface changes with vacuole alteration of the basal layer keratinocyte, and very sparse superficial perivascular lymphocytic infiltrate. Now, chronic cutaneous or discoid lupus erythematosus, or DLE. The most common type of cutaneous lupus is the discoid lupus erythematosus. Most often, it is seen on the face, scalp, ears, and lesions may develop, unlike all other types, on sun-protected skin. The changes in discoid lupus erythematosus are deep, and therefore they may result in scarring. There is also a depigmentation with typically hypopigmentation in the central area and hyperpigmentation at the periphery of the lesions of DLE. Here are some clinical examples. As you can see here, we see plaques and patches and plaques with elevated borders, erythematous. Here is a plaque on the side of the chin, in this case, with very sclerotic looking scarred-like appearance. In addition, the borders are somewhat variegated and indurated. Here is the depigmentation in the central area of the lesions with hyperpigmentation at the periphery of a lesion of discoid lupus, again with scarring. DLE can be absolutely devastating for individuals, as we can see here on the faces of these two patients, because of the deep inflammation and subsequent scarring. So what do we do? What do we see histopathologically in cases of DLE? The main features are superficial and deep, perivascular, and periadnexal lymphocytic infiltrate. Not only do we see lymphocytes around superficial and deep vessels, but we see lymphocytes around follicular structures and around eccrine glands deep in the dermis and within the subcutis. Sometimes there may be edema of the papillary dermis. The epidermis shows a variable thickness. In some areas, it may be very attenuated, very thinned. In other areas, it may be very hyperplastic. One important feature for the DLE is the presence of follicular plugging. The follicles are, the follicular infundibular are dilated and they are filled with keratin plugs. At higher magnification, we can see the edema of the papillary dermis. We can see thickening of the basement membrane. This pink corrugated material here is the basement membrane. The lymphocytic infiltrate is noted at the dermoepidermal junction with a few lymphocytes going within the epidermis. There are, again, vacuolar changes of the basal layer keratinocytes and numerous melanophages because the lymphocytes go to the epidermis, they kill the keratinocytes. That's why here we have necrotic keratinocytes in the epidermis at a few levels. When the keratinocytes die, they go into the dermis and the pigment, melanin pigment that they harbor is engulfed by melanophages. Therefore, they produce hyperpigmentation clinically. It's important to note that the interface changes are not only seen in the overlying epidermis, but the hair follicles are also involved. Here we see two hair follicles. This one in particular has a lymphocytic infiltrate. In its vicinity, lymphocytes are focally present near the dermoepidermal junction, and there are numerous necrotic keratinocytes within the follicular epithelium. Similar changes in this hair follicle. At this higher power, we can see easily the thickened basement membrane material, and again lymphocytes at the dermoepidermal junction. Here is a necrotic keratinocytes at the junction. Similar changes in the infundibular portion of this hair follicle, and numerous melanophages as a sequela of the destroyed keratinocytes in the epidermis. Higher power, necrotic keratinocytes, and inflammatory infiltrate with vacuolar degeneration of the basal keratinocytes. Here is an example of a hair follicle with markedly dilated follicular infundibulum filled with keratinaceous debris. This is follicular plugging. Around the hair follicle, there is dense lymphocytic inflammatory infiltrate. If we look at the lower levels of the epidermis at the dermoepidermal junction, again, there are vacuolar alteration within the basal layer keratinocytes and numerous necrotic keratinocytes. Here are the necrotic keratinocytes again, vacuolar changes in the basal layer keratinocytes and dense lymphocytic infiltrate. In addition to superficial and deep perivascular lymphocytic infiltrate in lupus, often we find increased amount of mucin in the dermis. This bluish, stringy material in between collagen bundles is mucin, and it may increase the spaces between the collagen bundles in the dermis. If mucin is not easily appreciated on H&E, special stains such as colloidal iron or Alcian blue could be used in just to highlight the mucin in the dermis. But this is one of the features of lupus. Here is another example of DLE. superficial and deep, perivascular and periadnexal, extending down to the eccrine apparatus, lymphocytic infiltrate, perhaps some mucin. There is some fenestration between the collagen bundles deep in the dermis. The epidermis is focally very thinned. In other areas, it's hyperplastic. Again, thinning of the epidermis and hyperplasia at other areas. Lymphocytic infiltrate approaching the epidermis in some foci with vacuole alteration of the keratinocytes, necrotic keratinocytes, and thickening of the basement membrane. Another example, again with follicular plugging. Here are hair follicles filled with keratin debris and superficial and deep perivascular and periadnexal lymphocytic infiltrate. Obvious interface here, particularly around the hair follicle with melanophages in the superficial dermis and vacuole alteration of the keratinocytes in the basal layer. Here is a good example of a thickened basement membrane, particularly in this area. And again, vacuole alteration, involvement of the follicle, and numerous melanophages. Thickened corrugated basement membrane. Lupus erythematosus can cause alopecia, and this is the DLE type of lupus erythematosus. And again, this alopecia can be devastating because the lesions are, this of course DLE is a scarring alopecia, and the lesions can be very large, and they heal, if they ever heal, with scarring, and therefore this can present a big problem for the patients. Here is an example of biopsy from the scalp. We see numerous hair follicles, although overall their number is diminished, less than in a normal scalp. And we see a very dense, predominantly perifollicular lymphocytic infiltrate in the upper 2/3 of the dermis. The epidermis is slightly acanthotic. The rete ridges is effaced. Here we can see that the lymphocytic infiltrate is very dense and concentrated around the hair follicles. At some areas, the infiltrate attacks the dermoepidermal junction, where again there are numerous vacuolar changes in the keratinocytes of the basal layer of the epithelium. This is a PAS stain which highlights the thickening of the basement membrane in the overlying epidermis, and a little bit here within the follicular infundibulum. And there is increased mucin. This beaded stringy material in between collagen bundles is mucin. Lupus erythematosus tumidus. It creates induration of the skin and erythema, but there is no scale or follicular plugging. The epidermis basically is normal, not involved. Here are examples of tumid lupus, erythematus, nodular, indurated nodules on the face. There is superficial and deep perivascular and periadnexal lymphocytic infiltrate, which is composed of lymphocytes. I would like to, I apologize for the slide not being in focus, but I would like to point your attention to the fact that the epidermis is not involved whatsoever. There is only infiltrate in the dermis, and the infiltrate again is composed of lymphocytes and histiocytes sometimes, but lymphocytes is the predominant cell. And here is increased mucin in the dermis, dividing and enlarging the spaces in between the collagen bundles. You can stain the mucin with various mucin stains, as here with colloidal iron. Lupus paniculitis, or lupus profundus, presents with indurated plaques, predominantly on the face, upper arms, upper trunk, breasts, buttocks, and thighs. And here are some clinical examples. As you can see the epidermis is unchanged. There are some hyperpigmentation, but in this case, there are indurated plaques with a definite loss of tissue. They are bound to the subcutaneous tissue. In this case, we have a white indurated plaque. Here is another one here. And on histopathology, the main changes are deep in the subcutaneous fat. There are no epidermal changes, there are no dermal changes. Occasionally, there may be inflammatory infiltrate that extends into the dermis, but again, the main findings are in the subcutaneous fat. And what are the findings? Sclerosis, replacement of the subcutaneous fat with prominent fibrosis in the fibrous septae and involving the fibrous lobules. The next slide shows that the epidermis is absolutely unaffected, and the upper portion of the dermis in this case shows no changes. There are some inflammatory infiltrates here around the nexal structures in the deep reticular dermis, extending into the subcutaneous fat. Here is sclerosis or fibrosis of the subcutaneous fat with mainly lymphoplasmacytic inflammatory infiltrate. Here we can appreciate the lymphocytes and plasma cells within the infiltrate. Here is a portion of the deep subcutaneous fat with a fibrous septum that has been very widened by the sclerosis, and there is a residuum of the inflammatory infiltrate in this area. We can also see how this fibrosis extends into the fibrous septae and makes the entire area very sclerotic. One important clue to lupus profundus is the presence of aggregates of lymphocytes, lymphocytic follicles. These can be found throughout the subcutaneous fat. Here we have one with surrounding fibrosis, and this subcutaneous lobule shows completely necrotic adipocytes, and fibrosis has replaced basically the normal subcutaneous tissue that existed here before. Here is again the lymphocytic infiltrate. In addition to that, there are numerous plasma cells, and plasma cells are an important constituent of the inflammatory infiltrate in cases of lupus profundus. Many plasma cells together with lymphocytes. Sclerosis, complete replacement of the fat by fibrous tissue. As I mentioned, lupus erythematosus is a systemic disease. It involves not only the skin, but it involves serosal surfaces, the brain, joints, lymph nodes, kidney, heart, and we mentioned the lesions that we see in on the skin in lupus erythematosus. We discussed we discussed the butterfly acute lupus with butterfly blush, subacute lupus profundus, lupus tumidus, bullous LE. We had an example in acute lupus. Lupus pernio we haven't discussed, but this is the changes of lupus pernio are very similar to the changes in pernio. We see interface dermatitis with vacuole alteration of the basal layer, a few necrotic keratinocytes and lymphocytes present near the dermoepidermal junction, and sometimes around vessels of the superficial plexus in the superficial dermis and focally into the deep dermis. One thing I would like to mention, I don't have an example of that slide, but recently CD123 has been described as an immunohistochemical marker, which may help in the differential diagnosis between inflammatory conditions and lupus erythematosus. CD123 labels dermal-dendritic cells, and supposedly in any inflammatory condition, the CD3 positive dendritic cells are scattered, and they are not more than a few around the vessel. In lupus, they present in clusters. So these clusters are at least 5-6 cells, or I would say even more, maybe a dozen of cells together, again around vessels or in the interstitium. But clusters of CD123 positive cells is in favor of lupus, as opposed to other inflammatory conditions. Dermatomyositis. Dermatomyositis may be associated with occult malignancy, and it's important to look for that. The skin disease generally precedes the onset of symptoms related to the malignancy. Patients with juvenile dermatomyositis with an increased incidence of small vessel vasculitis and calcium have increased incident of of small vessel vasculitis and calcinosis cutis. So now let's look at the clinical presentation. It's a heliotrope rash around the eyes of patients with dermatomyositis, very typical. You can see it here around the eyes. And patients with dermatomyositis have split hemorrhages that affect the cuticles of their fingers. What do we see histopathologically in lesions of dermatomyositis? The findings are similar to those of lupus erythematosus, and in particular subacute cutaneous lupus erythematosus. However, in general, the inflammatory infiltrate in dermatomyositis is much sparser than in lesions of lupus. So we will see lymphocytes around the superficial plexus and near the dermo-epidermal junction, as we see here. Just a few cells around the superficial plexus, a few lymphocytes approaching the dermo-epidermal junction, one necrotic keratinocyte, and again, vacuole alteration of the keratinocytes in the basal layer. Interface changes, but very subtle. This is the usual finding of dermatomyositis. Here we can see many of the basal keratinocytes show vacuoles in their cytoplasm. Of course, there are melanophages and perivascular lymphocytic infiltrate. Gottron papules are these specific papules, and these are pathognomonic findings that appear on the knuckles of the fingers in patients with dermatomyositis. Here they are in different varieties. Histologically, what are the findings in a Gottron's papule? We see superficial perivascular lymphocytic infiltrate and lymphocytes abutting the dermo-epidermal junction, where there are necrotic keratinocytes and vacuolar changes of the basal layer. In other words, interface dermatitis with slightly hyperplastic epidermis above. These are the Gottron's papules. Here we can see better the necrotic keratinocytes in the epidermis and the vacuolar changes in the basal keratinocytic layer. Vacuoles in the keratinocytes, lymphocytic infiltrate around vessels of the superficial plexus, and necrotic keratinocytes. Systemic sclerosis or scleroderma affects predominantly women. There is induration of the skin with involvement of distal areas. People with scleroderma also can have Raynaud's phenomenon. Cutaneous ulcers are common, and it is in general systemic disease. It doesn't affect the skin only, but it can affect many other organs with problems that the sclerosis can possibly cause. Here are examples of fingers and hands of a person with systemic sclerosis showing multiple scars. And even from the picture, we can appreciate that there is induration. The picture shows lack of motion, although of course it's a still picture, but this is my impression anyway. Here are other clinical examples of this horrible disease, and sometimes the fibrosis can really be very bad. Often there is fibrosis around the mouth, plaques of fibrosis anywhere on the body of different variety. This one has a little bit of wrinkling of the epidermis with underlying fibrosis. Here are other areas of scleroderma. And here again, erythema with whitening and thickening of the skin. That's a horrible scleroderma on the extremity of this person. So what are the histopathologic findings? Just thinking about the clinical findings, obviously the skin is indurated. Why is it indurated? Because the entire reticular dermis often, or if not the entire, the lower levels of the reticular dermis are replaced by fibrosis. So here we have very thickened collagen bundles which are so densely packed together that the spaces between them are almost non-existent. In addition, we see inflammatory infiltrate around vessels and adnexal structures. It's in the lower portion of the reticular dermis and definitely at the boundary of lower reticular dermis subcutaneous fat. The place where one can find inflammatory infiltrate most often in cases of scleroderma is the boundary of dermis and subcutis, as in this case. Again, in the upper portion of the dermis, there is normal fenestration between collagen bundles and they are not thick. However, in the lower 2/3 of the dermis, there are very thickened collagen bundles with perivascular and periadnexal inflammatory infiltrate containing lymphocytes, and also one very important cell here is the plasma cell. So in morphea or scleroderma, there should be lymphocytes and plasma cells. If you see plasma cell, that would be in favor of this diagnosis if that is suspected but not entirely confirmed. Here we see lymphocytes around this blood vessel. In addition, there are plasma cells in the inflammatory infiltrate. Here is a very thickened fibrous septum, part of the subcutis. In addition, there are inflammatory cells at the border of this thickened fibrous septum with this lobule, which also contains numerous inflammatory cells. Very thickened collagen bundles, acellular, very few nuclei of fibroblasts, basically thickened acellular collagen bundles with inflammatory cells in between. Just briefly to talk about a rheumatoid arthritis, which can be juvenile and adult onset rheumatoid arthritis. I won't cover the clinical picture. I just want to show you some clinical photos of rheumatoid nodules. So rheumatoid nodules occur always near a joint. You cannot have rheumatoid nodule in the middle of a forearm or arm. They're always near a joint. And that's important when we send a biopsy and the clinicians asks us to differentiate rheumatoid nodule from deep GA, for example. So rheumatoid nodules are always near joints. And how do they look histopathologically? First of all, they are deep. The epidermis and the dermis are usually not affected, and we see the changes deep in the subcutis or soft tissues underneath. This is a low power view of rheumatoid nodule, and as we go to a higher power, we see that the central, let me go back to the first one, we see that in the center of this rheumatoid nodule, there is pink material. And then immediately next to that, there is something bluish. So on higher magnification, we see that the pink material is fibrinoid necrosis, but this is always eosinophilic, fibrinoid necrosis, and then there is a palisade of histiocytes rimming this fibrinoid material. In GA, in the center, there will be mucin, not fibrinoid necrosis, and mucin is usually blue when we stain it with H&E. So pink material, which is amorphous but dense amorphous pink material, which is fibrinoid necrosis, then palisades of histiocytes, and then outside of the palisade of histiocytes, fibrosis. Here is again the dense amorphous pink material, palisades of histiocytes, and fibrosis outside. And again, to discuss deep GA in the differential diagnosis, this material in the center of these granulomas will be mucin and blue. This is pink fibrinoid material, and in deep GA, of course, we'll see palisades of histiocytes. So the rest of the findings are very similar. And with this, I would like to thank you very much for your attention, and I would be very happy to entertain questions.
Thank you very much. It was a great tour of the connective tissue diseases. As you guys know, you can put your questions into the chat window, and I will be able to read that to Dr. Rossitza Lazova. Thank you again for the great lecture. My first question on this one, until others are coming in, would be that do you use in your practice the CD123 staining to differentiate between lupus and dermatomyositis?
Yes, but not very often. In fact, I rarely use it. I'm sorry, for dermatomyositis between the two?
Yeah.
I have to tell you that I haven't had a case that required that. I haven't seen a case of dermatomyositis in a few years now. So I haven't used it, but I am not aware. I have to read the literature. I think dermatomyositis does not show increased numbers. Is it correct, as far as you know, the clusters?
Yes, I think that's correct. And it is lupus that has a more increased number of 1 to 3 positives. As I personally not using it, so that's why I'm asking. That I think that Dr. McNiff published 1 or 2 papers on it, and I personally not using it. I'm just more relying on clinical pathological correlations, and the different kind of enzyme levels in the blood.
I agree with you, and I do exactly the same. As I mentioned, just recently I used it once, and I don't remember the exact case, but I think just it was a little iffy whether it's early or not, and I used it and it showed the clusters, so that helped me. But that's in all my practice, that's been the only time I've used it, because it's very sometimes it's hard. What is a cluster? Is 5-6 cells a cluster? You can't. I don't. As with everything else, immunohistochemical stains for me should be used cautiously and whenever necessary. So I don't use a lot of immunohistochemical stains.
I see. The other thing is, that would be interesting to do maybe. As you have a very special access to mass spectrometry, maybe to blast some of the samples of dermatomyositis and lupus and see if there is peak differences. I mean, that would be that's a crazy idea, but your results on the melanocytic lesions are extremely impressive. I mean, the ratio that you are able to tell benign from malignant, so maybe that would be also an interesting clue.
I think that's a great idea, which would be great to entertain in the future, that's for sure. Because mass spec is so specific with proteins and stuff, so it's very possible that they may mass spec may discover differences in proteins. between the two diseases. So it's very possible, absolutely.
And Rosita, do you use or used direct immunofluorescence in these connective tissue disorders for the diagnosis?
No.
No.
Because I don't think it's helpful.
Yeah, I mean, that's kind of, I'm just kind of trying to get to that with the residents, because, you know, there are different kind of views on whether it is useful or not. But we also see a lot of negative specimens. And we basically say that if it is if you consider lupus, then I think that in case of bullous lupus is actually a good thing to have, and also in cases if you are like in a SCLE patients, a chronically sun-exposed area would be, so sun-exposed and the chronic lesion are usually the ones that are coming back as containing the lupus band.
Yeah, occasionally, I mean, in specific cases, I agree with you that it may be useful, but in everyday cases, what's the point?
Yeah.
Pathology correlation, blood work, following up the patient, and everything is much more helpful.
I agree with you. So with that, I really thank you again for coming on and presenting this beautiful talk to us. I think that pictures were extremely good. I really loved your distinction that you made between, you know, acute lupus and the cellular infiltrate, that the neutrophilic and then later on the lymphocytic infiltrates were very interesting. Actually, one more question before I let you go is that in cases of the deep lupus cases, lupus profundus cases, how many times do you run into subcutaneous panniculitic T-cell lymphoma, or how often do you see those T-cell dyscrasia phenomenon that was described in the literature?
Right, that's a very good question, because this may be a problem, deciding in between lupus profundus and subcutaneous panniculitis like T-cell lymphoma. I have had one case that clearly we couldn't tell which one it was. We sent the case for clonality, and it came back as clonal, and then there was another lesion which we also sampled and sent, and the clone was the same. So this was helpful in making the decision that this was subcutaneous panniculitis like T-cell lymphoma. But in other cases, it may be very difficult, especially when there is only one lesion and everything else, normal blood tests and everything, could be very difficult. And I see this as probably the only method that can help.
Yeah, I think that probably, and I totally agree with you, in those cases we have to take a step back, because sometimes I feel that we may be diagnosing too much and we can subject the patient to too much treatment. So,
yes,
because we had also a couple of cases that were, like you said, positive with the genes, and it was, we can put into that diagnostic category. We saw the rimming around the fat with the atypical T cells, but on the long run, I'm talking about, I'm not really long run, but like 2-3 years, we don't or did not have recurrences in those cases. Anyway.
Right. Yeah, that's a great point. And in general, that's my my view of life and diseases. Be very conservative when you are in doubt, and just don't harm. The first thing is don't harm the patient, and just follow up, and if necessary, do other tests and biopsies until you determine the correct diagnosis, if it's dismal and you have to take action.
Yeah, I completely agree with you. Well, again, thank you so much, and I hope we will meet you, you know, with another talk in the future, and obviously we will see each other hopefully in the either the ASDP, ISDP, or another international meeting. But thank you so much, Rossitza, to present for us today.
I would like to urge my colleagues to let me know, or let you know what topics they might want to hear. This was a very basic topic. I apologize for those who know everything because it is basic. But again, I wanted to reach a portion of the audience that may benefit from that. But I would be happy to talk about more specific things and more with more details, not that basic as this one, if there is interest. So I would appreciate.
Actually, there is interest for both because Dr. Prieto is working with Doru and probably me also included on a general derm path kind of a topic library, and this is a great talk for that we can say, okay, connective tissue diseases, and at the same time we are also working on a more advanced, more people who are subspecializing on dermatopathology. So both are very interesting. I don't know. I mean, for me, I'm super excited about your studies on mass spectrometry. I think that's an amazing new area that needs a lot more, and to be, I'm not saying to advertise, but that people are actually know about it, and it is getting a little bit more mainstream as the CGH or other genetic studies are. So.
Oh, great. Well, I would be happy whenever you want, actually.
Okay.
Because I have prepared. I can do it tomorrow. I can do it now. I would be happy to talk about that if you find this interesting.
I absolutely do. I absolutely do. Okay, but we will talk about it, and that would be a phenomenal thing to hear you speaking on that, because I think that, like I'm saying, you are a pioneer of that technique, and you know probably the most on that, and it would be a good way of disseminating knowledge around the world that there is another very effective diagnostic method. So we kind of, with the FISH test and with the CGH, I mean, the FISH, I'm not really a big fan of it, but the CGH, I like to do it. But this test is another thing that could be extremely helpful in difficult cases.
Yes, wonderful. Well, I'd like to thank all participants, and I want to, on our behalf, on theirs and mine, to thank you and the other organizers for putting your time and effort into providing this to everybody, whoever wants to do it in the world. This is an incredible effort on your part, and it's very much appreciated.
Thank you very much, Rossitza. So for you, we are going to the evening, so good night for you, and good night for everyone, or some of those folks who are logging in from, the eastern areas, maybe, good morning. Hope to see you soon with another talk. Bye-bye. Good night.
Bye-bye, everyone. Bye.